Hello guys, welcome to Pharmacological channel. So please don't forget to subscribe and like the channel. Today I'm going to talk about the pharmacology of anticoagulants. As shown in the previous video, platelets aggregation play an important role to stop bleeding, and in addition to that, overactivation of platelet aggregation could produce a thrombus which leads to ischemic events such as myocardial infarction or ischemic stroke. In addition to that, the coagulation pathway also contributes to the clot formation, starting from the extrinsic pathway, and the name tells the story since the initiation of this pathway caused by the factor from extravascular site. So normally, if the blood vessel remains intact, the extravascular cell could not contact with the intravascular components. But once the blood vessel get damaged, so the cells expressing tissue factor will be exposed, including pericytes, fibroblasts, and smooth muscle cells. And tissue factor could activate factor 7 to factor 7A and form a complex with tissue factor to convert factor 10 to factor 10A. This is extrinsic pathway. For the intrinsic pathway of coagulation, starting from the negatively charged surface, such as the phosphatidylserine exposure from the activated platelets, or the polyphosphate secreted from activated platelets. These molecules have negatively charged on its surface, so it could promote the intrinsic pathway of coagulation to activate factor 12 to 12A, and then factor 12A will convert 11 into 11A, and factor 11A will convert 9 to 9A. After that, factor 9A and 8A will form a complex to promote the conversion of factor 10 into factor 10A, or active form of factor 10. During this process, calcium also involved, which could be referred to as factor 4 for the coagulation pathway. So both extrinsic and intrinsic pathway produce activated factor 10A and will be undergo a common pathway by working with factor 5A in the form of complex to convert prothrombin or factor 2 into factor 2A, and thrombin will convert fibrinogen or factor 1 into a fibrin monomer or factor 1A. In addition, thrombin could activate factor 13 into 13A, which promotes the fibrin cross-linking to form a fibrin network during coagulation process. So together with the platelet aggregation, the coagulation could produce a firm formation of the clot to prevent bleeding. And as I mentioned before, overactivation of the platelet and the coagulation cascade could lead to a thrombosis, which occlude the blood flow to the tissue, leading to the sign and symptom of ischemic events such as myocardial infarction or ischemic stroke. For today, we will talk about anticoagulants that could block or inhibit the function of the coagulation cascade. However, normally our body have endogenous anticoagulation process. For example, the endothelial cell could release a prostacyclin or PGI2 and nitric oxide, which have antiplatelet activity to promote a resting state of the platelets. Also, on the membrane of an endothelial cell has a thrombomodulin, which could bind thrombin to activate protein C, which function with protein S in order to inactivate factor 5A and factor 8A. The tissue factor pathway inhibitor released from endothelial cell could also inhibit tissue factor and factor 7A complex. Finally, the heparan sulfate on the surface of endothelial cell could bind and activate antithrombin to inactivate the factor 10A and thrombin, and also a clotting factor from intrinsic pathway such as factor 12, 11A, and 9A. Moreover, once the clot formation block the flow of the blood in the vessel, it will activate the endogenous fibrinolysis system to release tissue plasminogen activator, and these will bind on fibrin together with plasminogen, and tissue plasminogen activator will convert plasminogen into plasmin, and plasmin will cleave fibrin, leading to a fibrin degradation to lyse the clot. There are two main types of anticoagulants, including indirect acting anticoagulants and direct acting anticoagulants. We call it indirect acting because these drugs act indirectly to inhibit the function of clotting factor. These include unfractionated heparin, low molecular weight heparin, fondaparinux, warfarin. For the direct acting, it is straightforward. So these drugs could inhibit clotting factor directly, such as a direct thrombin inhibitors or direct factor 10A inhibitors. First, we're looking at the heparin and its derivatives that could be classified into unfractionated heparin, low molecular weight heparin, and fondaparinux. For the unfractionated heparin, it has a long chain of polysaccharide. It is a sulfated polysaccharide which has a pentasaccharide region to bind and activate antithrombin. And if unfractionated heparin form a binary complex which includes antithrombin and factor 10A, it will inactivate factor 10A. But if unfractionated heparin form a ternary complex, it means that the pentasaccharide region will bind and activate antithrombin, whereas the terminal region could bind with thrombin or factor 2A, and these ternary complexes could inactivate thrombin. But for low molecular weight heparin, it has a shorter polysaccharide chain, so it has a pentasaccharide to bind and activate antithrombin to form a binary complex to inactivate factor 10A, but the region that could bind with thrombin is shorter than unfractionated heparin, so it could not bind thrombin properly, so it hardly to form a ternary complex in order to inactivate thrombin. It means that low molecular weight heparin is more selective to inhibit or inactivate factor 10A than thrombin. For fondaparinux, it is a synthetic polysaccharide which has only a pentasaccharide region like this to bind and activate antithrombin and inactivate factor 10A. So this drug is the most selective factor 10A inactivator compared to others. For the unfractionated heparin, as I mentioned, it is a sulfated polysaccharide with a long chain of polysaccharide, and it has a pentasaccharide region for binding with antithrombin. And unfractionated heparin could inactivate the clotting factors in the intrinsic pathway, such as factor 12A, 11A, 9A, and also factor 10A and thrombin in the common pathway. In terms of pharmacokinetics, unfractionated heparin is highly bound to the plasma protein, and it has a short half-life, like 30 minutes to 1 hour and a half. It is metabolized mainly by the plasma enzymes or the cells such as the endothelial cells or macrophages, particularly in the low dose, which is a saturable kinetics. But in higher dose, unfractionated heparin is degraded by the kidney, which is a non-saturable process. When using unfractionated heparin, you need to monitor the activated partial thromboplastin time, or APTT, which is the testing for the activity of intrinsic pathway, since unfractionated heparin inactivate the clotting factor in the intrinsic pathway mainly, and also factor 10A and thrombin, which is in a common pathway. And the target APTT level should be about 1.5 to 2.5 times of the control. Means that unfractionated heparin has a narrow therapeutic index. And the adverse drug reactions of this drug is bleeding, and also heparin-induced thrombocytopenia or HIT. And in some cases, the patients may develop osteoporosis, particularly in a long-term use over 1 month period. For low molecular weight heparin, the structure is shorter than unfractionated heparin, and the action is more predictable. These drugs don't need the laboratory parameter like APTT to monitor that effect, and it has a good bioavailability following subcutaneous injection. It has a short plasma half-life, about 4 hours. However, these drugs could produce a prolonged action, since it has a mean residence time for anti-factor 10A of about 7 hours. It also has additional mechanism that stimulates the secretion of tissue factor pathway inhibitors and endogenous anticoagulation process from the endothelial cells. So these mechanisms contribute to a long duration of action, leading to a twice daily dose and or once daily dosing. Sometimes the low molecular weight heparin, such as enoxaparin, could be administered intravenously as a loading dose, particularly in the acute setting like ST segment elevation, myocardial infarction, or STEMI. In terms of adverse drug reaction, low molecular weight heparin have a lower rate of HIT, but if the patient got HIT from unfractionated heparin, we would not use a low molecular weight heparin in these patients, since it can cross-react with unfractionated heparin to produce HIT. The last one for heparin derivative is fondaparinux. It's a synthetic short pentasaccharide chain which inactivate antithrombin. So it specifically inactivate factor 10A. It has good bioavailability, almost 100% after subcutaneous injection. It has long half-life, almost 24 hours. But once you stop using the drug, it may take like 2 to 4 days for its offset of action. The incidence of hits from fondaparinux is very rare. So in patients that got hit from unfractionated heparin or low-molecular heparin, fondaparinux might be a drug of choice, since the incidence of hit from this drug is very rare. This table summarizes the pharmacological properties of heparins and the derivatives. So for unfractionated heparin, it targets or inactivates the intrinsic pathway, including factor 12A, 11A, 9A, and also the factor 10A and thrombin in the common pathway. But low-molecular weight heparin, such as enoxaparin, nadroparin, dalteparin, are more likely to inhibit or inactivate factor 10A rather than thrombin. And fondaparinux is the most specific inactivator of factor 10A. In terms of renal excretion as unchanged form, for unfractionated heparin, there's no excretion in an unchanged form, but low-molecular heparin and fondaparinux, there's some certain amount of drug that are excreted as unchanged form through the kidney, so it requires a dose adjustment in patients with renal impairment. For the antidote of unfractionated heparin, we can use protamine sulfate as an antidote. Since it is a positively charged, it could bind a negatively charged on structure of unfractionated heparin and neutralize the effect of unfractionated heparin. But for low molecular weight heparin, protamine sulfate could produce only 60% of effect as an antidote. In terms of hit incidence, as I mentioned, if patients got hit from unfractionated heparin, they could not use low molecular weight heparin since it can cross-react. The drug of choice might be fondaparinux if you have no other better choice, since the incidence of hit is very rare. The last one for indirect anticoagulant is warfarin. So this is in the liver. Normally, the procoagulant or procoagulating factors, including factor 2 or prothrombin, factor 7, factor 9, and factor 10, and also anticoagulant proteins like protein C, protein S, and protein Z are produced by the liver using the enzyme gamma-glutamyl carboxylase enzyme. And these enzymes require reduced vitamin K or vitamin K hydroquinone as a cofactor in order to produce these procoagulants and anticoagulants. Once the reduced vitamin K is used, it is converted to oxidized form or vitamin K epoxide, and this vitamin K epoxide requires an enzyme called vitamin K epoxide reductase to produce a vitamin K quinone or vitamin K1, and further converted by vitamin K reductase to a reduced vitamin K or hydroquinone form. It's kind of vitamin K recycling. The mechanism of action of warfarin, it inhibits vitamin K epoxide reductase, so it reduces the conversion of oxidized vitamin K into a reduced form to act as a cofactor of gamma-glutamyl carboxylase in order to produce these factors. So you reduce the synthesis of procoagulants and anticoagulants from the liver, particularly factor 2 or prothrombin, factor 7, factor 9, and factor 10, and protein C, S, and Z. And warfarin require at least 3 to 7 days to produce the onset of action. Since you can see here, the plasma half-life of existing clotting factor in the blood quite long, like prothrombin has a plasma half-life of 40 to 70 hours, or factor 10 has a half-life of 30 to 50 hours. So it requires a long time in order to clear or eliminate all of these clotting factor from the blood. This is why warfarin needs at least 3 to 7 days in order to produce the onset of action. And during this phase, it requires a more rapid acting, such as unfractionated heparin or lower grade heparin, to control the initial period of warfarin using. And while using warfarin, we need to monitor the international normalized ratio, or INR, which is the testing for the activity of clotting factor in the extrinsic pathway, and the target range would be 2 or 3. So it means that warfarin has narrow therapeutic index. And the antidote for warfarin is vitamin K1 or phytonadione, since vitamin K1 does not require vitamin K epoxy reductase enzyme in order to convert into a reduced vitamin K. So it bypasses this step. So it could act as an antidote of warfarin, especially in case of serious ADR like severe bleeding. For warfarin, it has a racemic mixture of S isoform and R isoform, but S warfarin is more potent than R warfarin. It's about 3 to 5 times more potent than R warfarin. Both of R and S isoform has high percentage of protein binding in the plasma, about 98 to 99%, and both of them have a long half-life. But in terms of metabolism, S-warfarin is mainly metabolized by CYP2C9 and 3A4, whereas our warfarin requires CYP1A2, CYP3A4, and CYP2C19, and these would affect drug interaction of warfarin. In the patients with genetic polymorphisms, like CYP2C9 poor metabolizers, so the enzyme could not metabolize warfarin properly. So these patients may have a higher plasma level of warfarin compared to normal people. So it increased risk of elevated INR or the risk of bleeding. In a similar manner, the patients that has a genetic variants of the WOC1 enzyme, leading to a more sensitive phenotype to warfarin. So using a normal dose of warfarin, these patients may be more sensitive to the effect of warfarin and increase the risk of elevated INR level and the bleeding risk as well. And there are several potential pharmacokinetic and dynamic interactions of warfarin with other drugs, the herbs, and foods. And for the serious ADRs, in addition to bleeding, warfarin may cause a rare serious types of adverse events, including purple toe syndrome or warfarin-induced skin necrosis. This type of adverse events is kind of necrosis formation, So patients may undergo a surgery to cut the necrotic tissue from the toe or from the tissue with high lipid content, such as the breast. Next one, we're talking about direct acting anticoagulants. There are two types. The first one is direct thrombin inhibitors. The second one is direct factor Xa inhibitors. For thrombin inhibitors, there are injectable drugs and oral drugs. The injectable drugs will be mainly used in patients who develop HIT, heparin-induced thrombocytopenia. The drug in this group, such as deserudin and lepirudin, bivalirudin, gatroban. But for the oral drug, the only available orally active thrombin inhibitors at the moment is the bigatran, etexalate, and the factor Xa inhibitors. They're all orally active drugs, such as rivaroxaban, apixaban, edoxaban, and betrixaban. Collectively, both oral thrombin inhibitors and oral factor Xa inhibitors could be called direct-acting oral anticoagulants, or DOACs, since they are all orally active and it acts directly to inhibit the activity of a clotting factor. Or they could be called NOACs, or non-vitamin K antagonist oral anticoagulants, since they are not a vitamin K antagonist like warfarin, and they are all orally active drugs. The first one is the bigatran etexalate. Since the bigatran is highly polar, so it is a difficulty for the absorption through GI tract. So the drug is formulated in the form of ester, the bigatran etexalate, as a prodrug. But once it is absorbed into the circulation, the enzyme esterase will cut etexalate and to get the bigatran, the active drug, to inhibit thrombin in a competitive, reversible manner. So the suffix of the name can tell that the bigatran is a thrombin inhibitor. The oral bioavailability of the bigatran etexalate is quite low. It's about 6 to 7%. And the bigatran is highly specific to thrombin. It binds to both free form or clot-bound form of thrombin, and it acts as a dose-dependent manner. For the adverse drug reactions of the bigatran, it includes bleeding or esophagitis or esophageal injury, since tartaric acid has been proposed to damage or injure the esophagus or esophageal mucosa, because it is a weak acid. So the recommendation for patients is drinking a sufficient volume of water, at least 150 ml, and to maintain at the upright position for at least 30 minutes to prevent the direct damage to the esophagus. And also in some patients, they may require proton pump inhibitors or histamine H2 receptor antagonists to heal the ulcer. And in some cases, the doctor may change to other anticoagulants, such as apixaban, rivaroxaban, or warfarin. There is a few incidents of impaired liver and kidney functions following the bigatran, and also a rare case of myocardial infarction or acute coronary syndrome. In the clinical trial called RELY trial, you see that higher percentage of myocardial infarction or acute coronary syndrome found in the bigatran treated group compared to warfarin-treated group. And some patients may develop allergic reactions to dabigatran. For direct factor Xa inhibitors, they are all competitive reversible inhibitors and bind to both free form and clot-bound form of factor Xa. It acts as a dose-dependent manner and very highly specific to factor Xa. So these tables show the specificity of these drugs to the factor Xa, including rivaroxaban, apixaban, edoxaban, and betrixaban. And Saban XA here indicates the mechanism of action of these drugs to inhibit factor Xa directly. So this table summarizes the pharmacological properties of NOACs or DOACs. For dabigatran, it has low bioavailability compared to factor Xa inhibitors. The duration of action of dabigatran is 12 hours, which is similar to apixaban. For other three drugs, rivaroxaban, edoxaban, and betrixaban has a 24 hours of duration of action, but only a low dose of rivaroxaban, such as 5 mg, could produce a 12-hour, a shorter duration of action. And importantly, dabigatran has a lower percentage of protein binding in the plasma, so large amount of drug, such as 80% of unchanged drug, will be excreted through the kidney, and it is dialysable since it has a lower percentage of protein binding in the plasma. So dabigatran needs a dose reduction in patients with renal impairment. For the factor Xa inhibitors, the two main drugs, which are rivaroxaban and apixaban, requires a metabolism by CYP3A4, and we have to aware of drug interaction through this pathway as well. Or other drugs like edoxaban, betrixaban, and dabigatran, they require a lower than 5% of CYP metabolism. However, some certain amount of factor Xa inhibitors are excreted through the kidney as an unchanged form. So all of them require dose reduction in patients with renal impairment. And interestingly, all these NOACs are the substrates of P-glycoprotein, so we have to be aware of the drug interaction through this mechanism as well. For the antidote of dabigatran, it is called idarucizumab, which is a monoclonal antibody directly bind to dabigatran. But for rivaroxaban and apixaban, the antidote is andexanet alpha. The structure of andexanet alpha is similar to factor Xa, so it could bind with Xa inhibitors, particularly rivaroxaban and apixaban. For the edoxaban and betrixaban, they require further clinical studies to confirm whether andexanet alpha could act as an antidote for these two drugs or not. For the pharmacokinetic drug interactions of NOACs, as I mentioned, the NOACs is a substrate of P-glycoprotein. For the P-glycoprotein in the gut, it pumps the drug out of the body. For the kidney, the P-glycoprotein also pumps the drug to be excreted through the urine. So if you induce the activity of P-glycoprotein, you will enhance the excretion of NOACs through the urine or through the gut. But if you inhibit the activity of P-glycoprotein, you would increase the blood level or the level of drug in the body, which may increase the risk of adverse drug reaction. And for rivaroxaban and apixaban, since they are the substrate of CYP3A4 in the liver, so the drug that may interfere with the activity of CYP3A4 may interfere the level of rivaroxaban and apixaban as well, whereas edoxaban require a non-CYP metabolism in the liver. This is the example of P-glycoprotein and CYP3A4 inducers, such as barbiturate, carbamazepine, rifampin, which could promote the decrease in plasma level of NOACs, which may cause lower activity or effect of the NOAC. But the drug that inhibits P-glycoprotein and CYP3A4, such as verapamil duloxetine, azole antifungal, clarithromycin, erythromycin, could increase the blood level of NOAC, which potentially increase the risk of adverse drug reaction such as bleeding tendency. And this is all about the pharmacology of anticoagulants. I hope you enjoy the lesson in this channel, and please don't forget to subscribe and like the channel, and see you in the next video. Thank you very much.